Hello students, welcome to this session. Now the objective of this session is you're going to give your NEET PG exams pretty soon, and for this NEET PG exam you have to understand what type of questions can come in the exam. It's not just about understanding the previous year questions, it's about understanding how questions are going to be framed, what type of questions they are going to be, and to see what pattern of clinical questions are coming up in the last 2-3 exams. So that is what we're going to discuss in this session, mainly to understand the pattern of question that comes up. And what I've done in my session differently is, instead of just asking you the PYQs, that is the previous year questions of NEET PG, I've tried to incorporate the previous year topics, the PYTs. And along with that, I've done a slight modification because we know that the exam pattern has changed now. There are going to be only 180 questions that are going to be asked. You have more time to answer each question, and that means that there is going to be some long clinical questions that come up, and there is also going to be image and video based questions that are used much more in this exam compared to any other exam. So what I've done in this session is I've incorporated some video based questions, I've incorporated a lot of image based questions so that you can get a hang of what type of questions comes up and you get a practice on how a proper NEET PG simulation exam will be like. So that's what we will do in this session. What I've got here is 25 important high yield topics from which questions are asked. So we'll not just answer that question, we'll also go into a bit of concept between each question. Okay. So first what I want to do is give you a small advice as to how to approach a NEET PG exam presently. So the coming NEET PG exam, what can you expect? See, questions are going to be long, they are going to be clinical questions. You will have a big paragraph of questions given to you, and I know many students will get confused when they see such a long question because they don't know what to focus on. See, what I want you to do whenever you get a long question is to focus on the keywords. Look at what are the keywords that can help you clinch the diagnosis. So always in a long clinical question, focus on the keywords and expect there to be video and image based questions. There are going to be a lot of image based questions and also a few video based questions will come up in this session. So expect those questions, understand which questions can go into video based questions. For example, a topic like pathological gait, where you see foot drop, Trendelenburg gait, all of that now suddenly becomes a very important topic because a lot of clinical questions can come from there. Another topic is biomechanics of the hip. From there, a lot of tests can be given as a clinical question, and that might be something you'll have to answer in the question. The last thing is two-layered questions. See, INI-CET always had long questions where they used to not just ask you the diagnosis. See, normally there was a one-liner question asked in NEET PG where they'll give you a one-liner and you'll have to answer what is the right answer. But the approach has changed now. Now the NEET PG exams along with the INI-CET exams are going to be a more layered question where they'll expect you to decode what the diagnosis is and then answer a question based on that layer. So the first layer of the question will be to diagnose what this clinical question is. And the second layer, the question directly will ask you an MCQ based on that topic. So you'll have to first decode the diagnosis and then answer the MCQ. So expect questions like that to come up in the coming exams. Okay. So let's start with our questions. We have 25 questions with us. So let's understand each of these questions. So the first question is, a 22-year-old man comes in with chronic low back pain for 8 months. The pain is associated with early morning stiffness lasting 2 hours. And it improves with exercise but not with rest. He gives a history of previous episodes of anterior acute uveitis. On examination, lumbar spine movements are restricted, lumbar lordosis is reduced. What is the most appropriate investigation for detecting the disease at an early stage? See, this is a two-layered question where they want you to tell what the diagnosis is and then which is the best investigation to detect this disease in the early stages. So a classical two-layered question. So your options are CT scan of the SI joint, MRI of the SI joint, anti-CCP antibodies, and X-ray of dorsolumbar spine. Now I'll give you 10 seconds. Think of the answer and put it up in the comment box. So see the keywords. I've highlighted few of the keywords for you to understand. Find out what the diagnosis is. Even if you know what the diagnosis is, put that up in the comment box as well. Along with that, tell me what investigations are there. Okay, what is the best investigation to diagnose this disease? So your first layer of question will be, what is the diagnosis? Second layer is which is the best investigation to detect it in an early stage. Right. So what do we have here? In our question, we have a young man who has chronic low back pain for 8 months. He has early morning stiffness lasting 2 hours, and they've given this paragraph that it improves with exercise but not with rest. And there is history of anterior acute uveitis, lumbar spine movements are restricted, and lumbar lordosis is reduced. So this patient has symptoms in the back, axial skeleton involvement is there. Along with that, they've told you this paragraph that it lasts for 2 hours, improves with exercises but not with rest. That is a classical feature of inflammatory pain. What happens in inflammatory pain is because there is a lot of inflammation causing pain in such patients, as they move, circulation improves, inflammation reduces, and patient feels better. But when they rest, that same inflammation process increases and patients end up having pain. If it was degenerative, in patients with degenerative pain, when they move, the pain increases, when they rest, the pain reduces. So this is an inflammatory kind of pain which is affecting the axial skeleton. Mainly the spine movements are restricted, and this patient has morning stiffness and chronic low back pain, and this patient is a young male. He is a young patient. If it is an elderly patient, we think of conditions like rheumatoid arthritis, but this is a young male who has all of these complaints. So what is the diagnosis here? See, when you see features like anterior uveitis, you suddenly think of seronegative spondyloarthropathy. Do you guys remember what seronegative spondyloarthropathy is? It is a group of autoimmune disorders which have few things in common. That is, it occurs before 40 years. It is an inflammatory arthritis of the axial skeleton with some involvement of large peripheral joint. There is absence of rheumatoid factor. There is strong association of HLA-B27, and there is presence of uveitis. So our patient has this, our patient has this, our patient has this criteria. So this is a seronegative spondyloarthropathy. Now, what are the seronegative spondyloarthropathy? The way we remember them is this mnemonic, that is PEARS, P-E-A-R-S, and the diseases are psoriatic arthritis, enteropathic arthritis related to Crohn's and ulcerative colitis, ankylosing spondylitis, Retter's syndrome, and Safo syndrome. These are the 5 conditions. Now tell me, in this, which one will have all of these features of restriction of lumbar mobility, pain that is there on morning stiffness and all of that? Yes, that is seen in ankylosing spondylitis. Yes, few of you got that right. Ankylosing spondylitis is a condition where we end up getting these kind of symptoms. So a patient with ankylosing spondylitis will have a presentation like this. There will be a young male, he will have chronic pain, he will have stiffness of the back, and he walks with a stiff back because his whole spine is fused. What happens in ankylosing spondylitis is enthesitis, which results in the whole spine fusing into one. It starts at the SI joint and then goes into the lumbar and rest of the axial skeleton. So mainly axial skeleton involvement, SI joint is more commonly involved. And classically, pain will be more on getting up from the bed or period of inactivity, but relieved by activity. It will be relieved by activity. That is an inflammatory kind of symptoms that you will commonly see. So this is ankylosing spondylitis. Now few things that you have to know in ankylosing spondylitis is, one, the clinical tests that we do in ankylosing spondylitis. See, commonly SI joint is the first joint to be involved in ankh-spond. First joint that gets involved in ankh-spond is SI joint, and then it goes into lumbar spine. It also causes enthesitis. It also causes enthesitis in different areas. It can cause enthesitis along the costovertebral junction. So here it can cause a problem in which patients will have decreased chest movements because of costovertebral inflammation, or patients will have heel pain. Because of this kind of enthesitis. So heel pain is common. Chest pain along the costovertebral joint is also common. So decreased chest movements is one clinical test which can help us pick up ankylosing spondylitis. Then we test for sacroiliitis because that is the first joint that gets involved. So SI joint involvement can be tested by Ganselan's test, figure of 4 test, and pump handle test. And I want you to remember each of these tests. Go back and see how each of these tests are done. For lumbar spine restriction, we do something called as a modified Schober's test or the Schober's test, and that is going to tell us if the patient has ankylosing spondylitis or not. So these are the three tests that we commonly do. Then coming to the investigations, X-ray is helpful. Yes, X-ray is helpful, but it is helpful only when patient has established sacroiliitis. If you can see here, this is an X-ray of a normal patient's spine. Here you can see that patient has a normal open joint. Patient has a normal open joint with no sclerosis seen in the bone. So both sides are normal. But look here, look here, look here. See, there is a lot of sclerosis and there is fusion. It has become a single area. So it is fused. So this is a feature of bilateral symmetric sacroiliitis, which is a hallmark of ankylosing spondylitis. So in an X-ray, how do you pick up these features? One is you look at the SI joint if there is bilateral symmetrical sacroiliitis. Another thing is because there will be fusion of the disc, there will be fusion of the vertebrae, it will result in bridging osteophytes. So you will notice osteophytes like this. See, if you see an osteophyte like this, that is because of degeneration. This is not a bridging osteophyte, okay? This is a different type of osteophyte or a syndesmophyte. But in a case of ankylosing spondylitis, patients will have syndesmophytes like this, which are marginal and which are fusing the vertebrae into single bone. Can you see how even the disc have calcified at every level? So it has become a single bone. So this is again a feature of X-ray feature of ankylosing spondylitis. Another feature that you will notice is even the sacrospinous and the supraspinous region. So this sacrospinous region, all of that also ends up becoming calcified. So all of that ends up becoming calcified. So this is your supraspinous and interspinous, sorry, not sacrospinous, interspinous, supraspinous and interspinous. These also end up calcifying, and when they calcify, it looks like there is a dagger that is kept on the back. So this looks like the shape of a dagger. So it is called as a dagger spine. So it is called as a dagger spine. Another feature, because the whole spine fuses into one, it looks like a bamboo spine. It looks like a bamboo spine, okay? But these are all features in the X-ray which you see much later in a patient with ankylosing spondylitis. If you want to pick up ankylosing spondylitis at the earliest, X-ray is not the best investigation, nor is CT, because what you want to see in ankylosing spondylitis early is enthesitis. You want to see that early enthesitis that starts developing, and the best way to pick that up is by doing an MRI. Okay, MRI is the best investigation, the earliest investigation for ankylosing spondylitis. And when you get an MRI, you will notice the MRI like this. You will see these kind of shiny corners which are representing enthesitis. This is because there is enthesitis happening in that corner. That is why there is a shiny corner seen there, which is also called as a Romanus lesion, and these are early signs of ankylosing spondylitis. Another feature is spinal pseudoarthrosis, which you can see in an MRI and a CT as well. So remember this, the earliest investigation for ankylosing spondylitis is MRI. Okay, it is MRI, but also you have to remember few other clinical signs as well. Now, how do you diagnose a patient with ankylosing spondylitis? If a clinical question comes where they want you to diagnose ankspond, you have to use something called as a modified Nevi-Ox criteria, where radiologically you have to pick up one sign, only one sign, the most important one, that is bilateral symmetric sacroiliitis. Clinically, patient should either have chronic low back pain more than 3 months, which should be inflammatory, or limitation of lumbar mobility, or limitation of chest expansion less than 2.5 centimeters. If any of one clinical sign and one radiological sign is present, then this patient is definitively a case of ankylosing spondylitis. Okay, so in this question we have a lot of clues. There is chronic low back pain for more than 8 months, that is one criteria in the modified Nevi-Ox criteria. Another is early morning stiffness lasting nearly 2 hours, and inflammatory pain. These are the features of inflammatory pain. So all of this are suggesting that it could be ankspond. Along with that, you have acute anterior uveitis, which is again seen in ankylosing spondylitis. So lumbar spine movements have reduced. Yes, that is expected. Lumbar lordosis is reduced. So in this, CT is not the right investigation. Anti-CCP, this is done for RA, rheumatoid arthritis. X-ray of dorsal lumbar spine will give you features like bamboo spine, marginal syndesmophytes. All of these will be seen, but these are not early symptoms. These are not early features. Okay, the earliest feature you will see in MRI. So MRI of the SI joint, they might give you two options, MRI of lumbar spine, MRI of SI joint. Which is more important? See, SI joint is first involved in ankylosing spondylitis. So MRI of SI joint is the best investigation done here. Okay. So that is the first question. Now a little bit of wisdom. So between each question I've put up few things, few wisdom topics that are there here. So a lot of students ask how many questions to attempt in NEET PG. So I'll tell you now, because 180 questions are there, it is imperative that you answer as many questions as possible. At least near to 175 questions have to be answered if you have to come above the 90th percentile. If you have to come above the 90th percentile. See, what has happened is the competition has increased significantly. Before, 80% correct answers in NEET PG would get you very good marks 3 years ago. But now 80% correct answers is not getting you any good ranks, and that is why you have to answer more than at least 175 questions in this exam. Okay, at least 175 questions, right? Okay. Now question number 2. A 68-year-old man is evaluated for progressive deformity of his right leg. His helmet has become tight over the past few years. He reveals increased warmth over the affected bone with bowing of the leg. Radiographs demonstrate mixed osteolytic and osteosclerotic changes. Lab shows elevated serum alkaline phosphatase with serum calcium, phosphate and PTH within normal limits. What is the likely diagnosis? And your options are osteomalacia, Paget's disease of bone, primary hyperparathyroidism and skeletal mets. Okay, can you tell me what the answer is? Think of each of these diseases, understand what these metabolic disorders are, and then you will be able to answer this question. Please put your answers up in the chat box. Okay, so let's understand each of these conditions before we go into the answer. Okay, so first let's understand what is osteomalacia. So osteomalacia is nothing but a counterpart of rickets, where patients have defective mineralization. They have a defective mineralization, and because of this the bone is weak. So when there is inadequate mineralization of adults bone because of vitamin D deficiency, that results in osteomalacia. And in patients with osteomalacia, they have low to normal calcium, low phosphate and increased ALP. So in our condition, calcium, phosphate, all of that were normal. PTH also is normal. So this is not osteomalacia. In osteomalacia, we have a problem with calcium and phosphate. Because of that, there is defective mineralization. The next is hyperparathyroidism. Let's understand what happens in hyperparathyroidism. We have two types of hyperparathyroidism, primary and secondary. So in secondary, patients have decreased calcium. There is a problem because of which patients have decreased calcium, and because of that there is increased PTH. We know this, that if there is decreased calcium, your body's feedback causes increased PTH, and this normalizes the calcium. Okay, this will normalize the calcium, and this gives out a negative feedback saying that okay, calcium has become normal now, so do not increase the PTH further. Okay, so normal PTH is given out. But in patients of secondary hyperparathyroidism, they have a problem with this negative feedback. There is a problem with this negative feedback, because of which patients keep having increased PTH, and that results in osteoclastic activity that keeps on increasing. Okay, so that is the problem in a case of secondary hyperparathyroidism. In primary hyperparathyroidism, patients have diseases like parathyroid adenoma and parathyroid hyperplasia. So because of the pathology in the parathyroid gland, they have excessive secretion of PTH that causes increased serum calcium, and there is no effect of negative feedback. So this is primary hyperparathyroidism. Here patients will have increased PTH, hypercalcemia and skeletal features like osteitis fibrosa cystica and subperiosteal bone resorption, and even brown tumor is common. So in our condition, PTH was not increased, hypercalcemia was not there, so this is not a case of primary hyperparathyroidism. Okay, then coming to skeletal metastasis. Yes, in skeletal metastasis, it is possible to have these lytic, sclerotic and mixed lesions. It is also possible for the patients to have some elevated ALP as well, but in metastatic disease, they have given you more clues. They have told you where the primary is, if there is any mass that is there somewhere, and they have given you some clues that tell you that there is a primary and the patient has some carcinoma problem. Okay, but in this question, all of those were not given. So the answer here by exclusion is Paget's disease. It is Paget's disease. And to understand Paget's disease, I want you to understand these four characters. The first one is an osteocyte, the second one is an osteoclast, the third one is an osteoblast, and the last one is a collagen. So in Paget's disease, the way I've taught metabolic bone disorders in my sessions is that I've taught what is wrong with those characters in every metabolic disorder. So in Paget's disease, the problem is this, that both your osteoclast and osteoblast have gone mad. So they are chaotically running around. One is causing increased bone formation, one is causing increased bone resorption, and that is called as Paget's disease. In Paget's disease, patients have a chaotic remodeling. There is a lot of bone being formed, and at the same time lot of bone is being resorbed. So patient may look osteoporotic in one stage, they may look osteosclerotic in one stage, and when this happens, patients will have different stages of Paget's disease. There will be an osteolytic stage, or an osteoblastic stage, or a mixed phase. So what happens because of this? Clinical features are your skull becomes thicker, and that's why patients give this classical symptom of changing of hat sizes, a very important keyword which you should have picked up in that question as well. Changing of hat sizes, and patients will have skull base that is flattened, that results in platybasia. There will be cranial nerve compression resulting in impaired vision, facial palsy, trigeminal neuralgia, and deafness. Patient's bone will be warm to touch because there is a lot of bone turnover and breakdown happening. So increased bone activity results in the bone being a little warmer than normal. There will be patients having otosclerosis causing deafness. There will be a lot of deformities in the bone. There will be an ape-like deformity because patients will have a short, kyphotic and bent limbs. Patients may have pathological fractures like banana fracture, spinal canal stenosis, nerve root compression, and there is something called as a Steele syndrome which a patient has in Paget's disease. And labs, if you see the labs of the patient, everything else, calcium, phosphorus, ALP will all, calcium, phosphorus, PTH, all of them will be normal. Only ALP, because there is high bone turnover, ALP will be high, and in biopsy they'll have a mosaic pattern. So two things that you will see in a patient with Paget's disease having. So what is the differential? So we know that metastasis is not there. In osteomalacia, we know that there is low calcium, high PTH, low phosphate. So that is excluded. In primary hyperparathyroidism, there is high calcium, high PTH, low phosphate. So that is excluded. But in Paget's disease, calcium, PTH, phosphate are normal. The only sign you will see is an increased ALP, So this is Paget's disease of bone, because here we have progressive deformity of the right leg. Helmet has become tight over the past few years, meaning the patient's skull size has increased. It's similar to changing your hat size. Helmet size has increased. Patient feels warmth over the affected bone, and there is bowing of the leg. And there is a mixed presentation of osteolytic and osteosclerotic changes, and the only blood change that you see is an elevated serum alkaline phosphatase. So Paget's disease of bone is the answer. So this is how you approach a question. I know all of this explanation is a little longer for you, but this is so that you understand how to approach every question. Okay, if you've studied all of that, it will come in your head. You'll be able to calculate quickly as to which is not the right answer, and with that you'll be able to arrive at the answer of Paget's disease. Okay, so that is what we're trying to do. Now question number 3, another important question asked 2 times in the last NEET PG exams. A 62-year-old woman presents with progressive low back pain associated with difficulty standing for prolonged periods. She has no history of significant trauma. On examination, lumbar movements are painful and restricted. What is the likely diagnosis? Is it spondylolysis? Is it spondylolisthesis? Is it Klippel-Feil syndrome? Is it spondylosis? Okay, this is the X-ray that is given to AP view and lateral view. AP view and lateral view. Can you tell me what the answer is here? If you understood the difference between spondylosis, spondylitis, spondylolysis, and spondylolisthesis, you will be able to answer this question as well. Okay, so what are we seeing in the X-ray? Forget the examination part, forget the clinical scenario that is given to you. That is different. Okay, even if you're not understood with that, just look at the X-ray here. So what I'm noticing in this X-ray, in an AP view, I don't see much. This is an LS spine. So this is my SI joints. These are the lumbar spine. So I don't see a lot of pathology in the AP view. But in the lateral view, what I'm seeing is that there is one vertebrae here and there is one vertebrae here, and there looks like there is a break of the pars here. Pars defect is seen here, and what I can clearly see is that these vertebrae, all of these vertebrae, they are in a same line, but this vertebrae has translated forwards, and I know this condition as spondylolisthesis. This is spondylolisthesis, okay, because the vertebrae has translated forward in this condition. So it is very important for you to understand the difference between these four conditions: spondylosis, spondylitis, spondylolysis, spondylolisthesis. So let's try to understand each of them. See, spondylosis is nothing but osteoarthritis of the spine. How you have osteoarthritis of the knee? If it happens in the spine, that is called as spondylosis, degeneration of the facets of the spine. That's all. That is spondylosis. Okay, that's all you have to remember. Spondylitis is ankylosing spondylitis, inflammation of the spine. Ankylosing spondylitis is inflammation of spine. So that is what spondylitis is. Then to understand lysis and listhesis, you have to understand that in the spine, we have this bone in between the superior articular process and the inferior articular process. The bone in between superior and inferior articular process called as the interarticularis, which is called as pars interarticularis. Okay, when that bone is broken, in a lot of people that bone is broken because of some congenital defect, that bone gets broken. So if that bone is broken meaning lysis, it is called as spondylolysis. Okay, now when that bone breaks, because the posterior part of the bone breaks, you will see it being like this. So you will see here that there is some break. Okay, there is some break that is seen. Now because of this break, if this vertebrae translates forward like that, if it goes forward, so one vertebrae comes here, one vertebrae comes here, so it translates forward like that, that is called as spondylolisthesis. That is called as spondylolisthesis. So in spondylolysis, if you draw a line, that line will still be matching because the vertebrae is not going forward, but in listhesis, that line is disrupted. Okay, that line is disrupted. So that is a big difference here. So this is how a normal vertebrae is. In this you can see that there is a break here. So this is called as spondylolysis. You can see the vertebrae is not translated forward. It is still in the same place. Here you can see that the vertebrae is translated forward. So this is spondylolisthesis. This is spondylolisthesis. Okay, so four important conditions to understand. Spondylolysis is where there is a defect or a fracture in the pars, but no obvious slipping of the vertebrae. Most commonly seen in L5 vertebrae. Okay, so this is an example of spondylolysis where you can see here that there is a break in the pars. Can you see there is a break in the pars? But if you draw a line along the vertebral body, there is no listhesis. There is no listhesis here. Now listhesis is when there is a forward slipping of the upper vertebrae over the adjoining lower vertebrae. Most common is L5 over S1. Second most common is L4 over L5. Okay, and this is how you will see it. So you can see here, this is one vertebrae. This is another vertebrae. You can see this has moved forward. So that is spondylolisthesis. Okay. Another thing you have to understand is in a normal oblique LS spine X-ray. In a normal oblique, not an AP, not a lateral X-ray, but in an oblique X-ray, you will see a pattern like this. Get a pattern like this. It is called as, what is it called as? It is called as a Scotty dog sign. It is called as a Scotty dog sign. So Scotty dog sign is normally seen in an LS spine oblique view. But when there is a lysis, this neck area which is there, this will become broken because the neck represents pars in a Scotty dog. So when you have a collared Scotty dog, that is called as spondylolysis. But in a patient with listhesis, you will notice that the Scotty dog head is detached and gone away. It is detached and gone away. So when you have a beheaded Scotty dog, that is called as spondylolisthesis. Okay, that is called as spondylolisthesis. So three important MCQs to remember. The Klippel-Feil syndrome might be something that most people don't know. So in Klippel-Feil syndrome, it's a congenital problem where patient's spine, which is normally supposed to have 7 separate vertebrae in the cervical spine, because of failure of segmentation, few vertebrae become fused. Can you see here how these two vertebrae are fused? Normally they are separate vertebrae. Here they are fused. So when they become fused, a patient is born with a short neck, with a low posterior hairline and restricted neck movements, and this is called as Klippel-Feil syndrome. That's all you have to understand. Congenital fusion of cervical spine due to failure of segmentation, most commonly seen in C6, C7, happens in the 3rd to 8th week of gestation. This is the triad. You have low posterior hairline, you have a short neck, and because of fused cervical spine, you have decreased range of motion. So if someone asks you what is the clinical triad of Klippel-Feil syndrome, it is short webbed neck, low posterior hairline, and restriction of neck movements. Okay, so in this question here, what you're seeing is forward movement of the vertebrae. So this is not lysis because it is forward moving. This is not Klippel-Feil because they are not shown you any fusion of cervical spine. This is a lumbar spine X-ray. It is not spondylosis because here there is more changes than spondylosis. So this best answer is spondylolisthesis here. Okay, spondylolisthesis is the best answer. Now coming to question number 4. See here, this is what I was talking about as a long clinical question. So they will give you questions like this, where you have such a long question and sometimes you get fatigued just reading the question. But remember students, the way to approach questions like this is to focus on the keywords. Try to highlight what keywords give sense to you. Okay, so let's apply that. Let's try to apply that here as well. So a 35-year-old male presents to the emergency department after falling from a ladder while painting his house. He landed awkwardly on his left forearm and complains of severe pain and swelling. On examination, the forearm is tense and swollen with marked tenderness on palpation. Passive stretch of the fingers elicit excruciating pain and patient reports numbness over the dorsal aspect of the hand. Distal pulses are present but weak. Which of the following conditions is patient most likely experiencing? Is it radial head fracture? Is it Workman's ischemic contracture? Is it Monteggia fracture dislocation? Or is it compartment syndrome? Can you tell me which are the keywords here? Let's not go into the answer now. Let's try to understand how to approach this question. So what do you think are the keywords here? So let me mark the keywords. So these are all the keywords. The forearm is tense and swollen. There is marked tenderness on palpation. The most important keyword is passive stretch of fingers eliciting excruciating pain, numbness over the dorsal aspect of the hand, and distal pulse is weak. It's present but it is weak. What is this a diagnosis of? What is this tense pain and passive stretch of the limb causing pain? What is this a classical symptom of? Yes, that is compartment syndrome, right? That is compartment syndrome. Okay, so compartment syndrome is the answer here, and you have to understand what happens in compartment syndrome. Very important pathophysiology to remember that in compartment syndrome, imagine this is a compartment, osteofacial compartment, where you have a bone, you have muscles, you have neurovascular structures, and it is all enclosed within a osteofacial compartment. So if the pressure on the compartment increases or the compartment volume decreases, that is going to cause increased compartment pressure. Okay, that is going to increase the compartment pressure more than the normal perfusion pressure, and this is going to cause, first in early stages, it is going to cause increased venous pressure that will decrease the perfusion pressure, which will decrease tissue perfusion, and in all of this patients will have an increased capillary permeability, and this will result in early muscle ischemia and nerve ischemia. And also because of increased capillary permeability, more exudates are going into the compartment, so there is more increase in compartment pressure. So this vicious cycle keeps continuing again and again and again. And in late stages, even the arterioles, which are thick actually, which don't collapse easily, even they decrease arteriolar pressure, because of which arterioles close and patients will have reduced weak pulse. So this patient has all of these features. He has features of early compartment syndrome where the pulses are still becoming weak. Okay, so this is a classical case of a compartment syndrome, and in these cases patients will have damage to the vascularity and the nerve. So when there is a vascularity damage, muscles will become ischemic. Till 4 hours they are reversible. At 6 hours some muscles will die, some will still be alive. So variable ischemia will be there. By 8 hours it becomes irreversible and goes into Workman's ischemia, which later goes into Workman's ischemic contracture. Nerve ischemia also, initially by 2 hours patient will have nerve conduction loss. By 4 hours patient will have something called as neuropraxia, which is again reversible, but by 8 hours that also becomes irreversible. So patient goes into paralysis. So patients will have paresthesia and paralysis here. Here patients will have pain on the ischemic muscles. Okay, so what are the features of a patient having compartment syndrome? The first symptom, the most important symptom, when ischemia starts, patients will have an ischemic muscle, which if you try to stretch passively if you try to stretch, patients will have severe pain. So pain on passive stretch is the first symptom of compartment syndrome, which everyone should be able to answer. Okay, so in this question, pain on passive stretch was given. That single keyword will help you clinch the diagnosis. Other than that, patients will develop paresthesia when nerve ischemia starts. When it becomes more, there will be paralysis and patients will have pallor and pulselessness. If you saw the question, in that they have given that the pulses are weak but still present. So many students get confused that, sir, pulse is present, then how can it be compartment syndrome? See students, that compartment syndrome, pulselessness is the last feature. That's why I have given it in an arrow form. The last feature, when arterial injury starts, that is when patients will develop pulselessness. So every patient with compartment syndrome does not need to have pulselessness. Okay, that is the last feature. But pain is the important feature. So the first thing you have to ask the patient is whether they have pain and whether this pain is present on passive muscle stretching. Is it present out of proportion to the injury? Is it not relieved by analgesia? Is it not relieved by immobilization? And this is a classical feature of an impending compartment syndrome. So these things are important. More than pulse, these features are important in any patient to be there. Okay, which sites is there where you see compartment syndrome? Most commonly it is tibia fracture, anterior compartment in children, and in forearm it is supracondylar humerus fracture resulting in flexor compartment syndrome. In the hands and feet also it can be present, compartment syndrome can be present. So treatment is known to everyone. We have to do an emergency fasciotomy within 8 hours, because after 8 hours everything becomes irreversible changes. So within 8 hours emergency fasciotomy of all compartments has to be done. Okay, so that is the answer, compartment syndrome. Another clinical question, let's do one more clinical question. Let's see whether you got the art of picking up keywords. Okay, so this is another very important question. A 26-year-old male has sustained a road traffic accident. He has been brought to the emergency department. You receive the patient, he undergoes the ATLS protocol. You diagnose him with a femur shaft fracture. You admit the patient and prepare him for surgery. 30 hours later, the patient develops shortness of breath. When you examine him, there are petechiae on his axilla and chest. D-dimer test done is negative. What is the diagnosis? Is it hemorrhagic shock? Is it fat embolism syndrome? Is it pulmonary thromboembolism? Or is it infective endocarditis? Can you tell me the answer to this? I will give you some time. Put your answers up in the comment box. So this is a very important question. You have to be able to answer such questions. And before you answer this question, you have to give some keywords as well. Which are the keywords that you see here? So let's try to understand the keywords. So these are the keywords: shaft of femur fracture, 30 hours, shortness of breath, petechiae of his axilla and chest. These are the important keywords here. Can you tell me the answer now? Okay, so the answer here is fat embolism syndrome. So this is an answer that everyone should answer. There should not be a confusion here, because it's a classical case of a patient who's presented with femur shaft fracture. Now what happens here? When a patient develops femur shaft fracture, in that area where the femur breaks, there is going to be a lot of fat globules that comes out, and this fat globules enter into the ruptured arterioles that are present. So in the area where the damage is occurred, the arterioles also get ruptured. So this fat globules enter the circulation through the femur shaft area where it gets ruptured, and through that emboli go into different areas. When it goes to the skin, you see these petechiae, mainly petechiae will be there in the axilla. There will also be retinal emboli that is present in patients. It can go into the brain as well. So what happens in these patients is, when they have a long bone fracture, fat is liberated from the bone. This fat is taken up by the venous system, the ruptured venules that are there, that take it up into circulation, and this fat embolize within 24 to 72 hours. Very important to remember, within 24 to 72 hours, the fat emboli goes into different areas. If it goes to the brain, patients will have confusion. If it goes into the skin, patients will have multiple petechial rashes. If it goes into the lung, patient will develop hypoxemia. They'll have pulmonary embolisms. If it goes into the retina, you will see a retinal emboli that is present. So in fat embolism, all of these features are seen. Even in a chest x-ray, you will notice a lot of pulmonary infiltrates that are present. Patient will also have an emboli, which is seen in a case of as punctures in patients with fundoscopies as well. So these are all features of fat embolism syndrome. If you still not understood this, there is a very important criteria that helps us decide fat embolism syndrome. I hope you all know the name of the criteria. It is a Gerd and Wilson's criteria. So how will you remember this Gerd and Wilson's criteria? Remember that there are two people, Gerd and Wilson. Both of them have 5 packs because they fart to stay fit. Why is this important? So we remember this is a Gerd and Wilson's criteria. So here the major criteria are: one in the lung, pulmonary edema; another in the skin, axillary petechiae; in the brain, CNS depression; in the eye, subconjunctival petechiae. These are the major criteria. Minor criteria are fever, anemia, retinal emboli, thrombocytopenia, fat globules in sputum and urine, high ESR, and tachycardia. Okay, so the way you will remember this criteria is Gerd and Wilson have PACS, P-A-C-S. This is a major criteria because they fart, F-A-R-T. This is the minor criteria. F-I-T, this is also the minor criteria. And how many packs do they have? They have 5 packs, 1 plus 4. 1 is the major criteria, 4 is the minor criteria. So if a patient has 1 major criteria and 4 minor criteria, then you know that this is a case of fat embolism syndrome. So that is a Gerd and Wilson's criteria. Now there was one more option given as pulmonary thromboembolism. Many times I've seen students get confused between thromboembolism and this, because even in a patient with trauma, thromboembolism is a very common complication. So how do you really differentiate between 3 important differentials? One is a patient going into hemorrhagic shock. Imagine a polytrauma patient comes to you, or a femur shaft patient comes to you immediately post injury. He'll have a lot of bleeding. Femur shaft, usually there will be bleeding of 1.5 liters. So when there is significant bleeding, he can go into hemorrhagic shock. Or the same patient can go into fat embolism, or the same patient can go into pulmonary thromboembolism. So the main criteria here is the time. If it happens within 2 hours of presentation, that is hemorrhagic shock. If it happens within 2 days of presentation, that is fat embolism, 24 to 72 hours. If it happens 2 weeks later, because the patient has been immobilized for a long period of time, that is pulmonary thromboembolism. So with this, we know the answer is fat embolism syndrome, and the treatment for that is high flow oxygen, IV fluids, mechanical ventilation with high PEEP, and high dose corticosteroids for the inflammation that is there. Okay, so let's go to the next question. So before I go into the next question, another pearl of wisdom, that do not try to keep too many things for the last 1 week of NEET PG exams. Only keep the topics that you're going to forget, or something that requires memorization, that should be reserved for the last week or the last 5-6 days. If you try to keep everything for the last day, this is how your condition will become like. Okay, so that is another pearl that I'm giving you. Now let's go into question number 6. Another important concept in trauma. A child sustained an injury as shown in the below radiograph. What is the classification used and what is the grade? Is it Garland's classification type 4? Is it Gartland's classification type 3? Is it Salter-Harris classification type 3? Is it Salter-Harris classification type 4? Now to answer this question, you have to know what these classification systems are, and they've given you an X-ray here. They want you to look at this X-ray and tell what the diagnosis is. So what I see here is that this is the elbow joint. Do you agree with me? This is the elbow joint. And I can see that the fracture has occurred here, somewhere proximal to the elbow joint. This has to be the supracondylar region. This has to be the supracondylar region. So the fracture is a supracondylar humerus fracture. You can see that. Now they're asking you, what is the classification system that you use for supracondylar humerus fracture? Is it Salter-Harris or is it Gartland's? Gartland or Salter-Harris? Yeah, it is Gartland's classification. Very good. It is Gartland's classification. So let's try to understand this classification system. So in supracondylar humerus fracture, the patient, it commonly occurs in children, and the fracture occurs here, just proximal to the elbow. That's what we saw in the X-ray as well. Common fracture in children, most common fracture, elbow fracture, most common fallen outstretch injury in children. The classification system is the Gartland's classification. Small mistake in the spelling there. So it is Gartland's. So this is the actual spelling, Gartland's classification. 3 types. One is type 1, which is undisplaced. So patients will not have a displacement here. In type 2, it will be displaced, but the posterior cortex, this part of the cortex will still be intact. In type 3, there is complete loss of contact between the 3. Complete displacement between the 2 fragments is seen. So this is the X-ray again. You can see here, this is a undisplaced type 1. This, there is a fracture here, but there is still an intact posterior cortex. So this is type 2. In type 3, you can see one fragment is here, one fragment is here. So that is a Gartland's classification. And the way to remember this, if you have a problem remembering these mnemonics, you follow this visual aid. Okay, so a garland in the supracondylar region. Garland in the supracondylar region. If you've seen old TV shows, you would have seen females wearing a type of floral arrangement here, which looks like a garland. So garland in the supracondylar region, Gartland's classifications for supracondylar humerus fracture. So that is how you will remember them. Okay, so again, let's go through the X-rays. Type 1, you will not see any fracture, but what you will see is that this kind of sign is seen. Some fat pad will be increased. So that is called as a Sale sign. That is called as a Sale sign. Okay, that is called as a Sale sign. So this is a Sale sign that you are seeing, anterior and posterior Sale sign. So fat pads both anterior and posterior will be normal. So patients will have an undisplaced type of fracture. Anterior humeral line will be bisecting the capitulum in the lateral view. Bowman's angle is normal, and this is called as a fat pad sign or a Sale sign. So that is type 1. In type 2, what you're seeing is there is a break in the fracture, but posterior cortex is still intact. So displaced with intact posterior cortex, anterior humeral line does not bisect the capitulum in the lateral view. Bowman's angle is increased. There is a medial tilt and shift. In type 3, you can notice this is one fragment, this is another fragment. So displaced fracture with no cortical contact at all. Okay, so keywords here are, it has to be a 6 to 10 year old child because it is commonly seen in that age group. It has to be a fallen orthostatic injury, pain and swelling of the elbow, inability to move elbow, and patients will have an S-shaped deformity of the elbow. Okay, that was about Gartland's classification. Now, what is a Salter-Harris classification? So Salter-Harris classification is mainly talking about epiphyseal growth plate injury. If you know that this is a growth plate that is there between metaphysis and epiphysis. So it has different regions. Let's quickly revise those regions. We have a germinal zone that is present towards the epiphysis, proliferative zone, hypertrophic zone, and zone of provisional calcification that is towards the metaphysis. So these are the different zones. So in a patient with a physeal injury, commonly what you will see is it is in the phalanx rather than distal radius, and the classification system for these physeal injuries are Salter-Harris classification. This is important. Salter-Harris classification is an important classification system. And how do you differentiate this Salter-Harris classification? See, in type 1, the fracture passes through the epiphyseal growth plate. It goes through the epiphyseal growth plate. Okay, Salter-Harris classification. So if the fracture is through the growth plate, that is type 1. In type 2, the fracture goes like this and goes above. It goes above like this. Okay, so this goes or crosses from the metaphysis. So it leaves a small fragment here. That fragment is called as Thurston-Holden fragment, and this is type 2. This is type 2. This is type 1. In type 3, the fracture goes through the epiphysis and comes distally out of the epiphysis here. Okay, goes distally through the epiphysis. That is type 3. And in type 4, it goes through and through like this. In type 5, it rams the physis. So it is crushing injury between the metaphysis and the epiphysis. So this is a crushing injury where it gets rammed. Okay, it gets rammed. So this is how you remember them. In type 1, there is slippage of the epiphysis. In type 2, it goes above. In type 3, it goes lower. In type 4, it is through and through. In type 5, it is rammed. So the way to remember this is slippage, this is above, this is lower, this is through and through, and in this the epiphysis gets rammed. So the mnemonic here is Salter, S-A-L-T-R. Salter is the mnemonic, and this is the table that I want everyone to remember. The best prognosis is in type 1 because germinal layer is not damaged. The worst prognosis in type 5 because germinal layer is damaged. So patients will have a growth plate injury, and growth arrest also can be a complication in these patients. Okay, so this is a Thurston-Holden fragment that is seen in type 2 where the fracture passes like this and goes above and exits from the metaphysis. So this fragment that you're noticing, it's called as a Thurston-Holden fragment. And these are examples of each type of Salter-Harris classification. In type 1, you have slipped capital femoral epiphysis. Okay, that is a example of type 1. Type 2, supracondylar humerus fracture is an example. Type 3, Tilloch-Chaput fracture is an example. Type 4, lateral condyle humerus fracture is commonly an example. And type 5, this wedge compression fracture of the spine is an example. So you have to remember this table as well, can be asked as a question in one of your exams. Okay. So the answer here, because you are noticing that this fragment and this fragment is completely displaced. So this has to be type 3 Gartland, not type 4, type 3 Gartland. So the answer is D, type 3 Gartland. Okay. So that is the answer of this MCQ. Now let's go into the next MCQ, another MCQ related to the same trauma. A child fell while playing and a cast was applied. On removal of the cast, the following deformity was seen much later. What is a likely injury to have caused this? Is it supracondylar humerus fracture? Is it a radial head fracture, a lateral condyle humerus fracture, or a mid-shaft fracture of the humerus? Can you tell me this? What does this deformity look like to you? A very common, very important, very famous MCQ that you all have to remember. Can you tell me the name of the deformity and also what is the answer of this question? So this is a gun stock deformity. This is a gun stock deformity where you can see that the limb has come close to the body. So we know this, that if any limb comes close to the body, we call it as valgus. We don't call it as varus. Sorry for that. So if it comes closer, we call it as varus. Okay, we call it as varus because it is coming closer. We keep the vulgar away. If it comes closer, it is called as varus. And if it happens at the elbow is called as cubitus. Do you agree? It is called as cubitus. So this is cubitus varus deformity. Cubitus varus deformity. If it happens in the wrist, it is called as manus valgus or manus varus. If it happens in the hip, it is called as coxa vara or coxa valga. If it happens in knee, it is called as genu valga or genu vara. Okay. So these are 4 important deformities to remember for you. Okay. Remember this, valgus goes away, varus comes inward. So here the limb is coming inwards. So it is called as varus deformity, and this kind of cubitus varus is commonly seen in supracondylar humerus fracture. And this is called as, what is it called as? It is called as gun stock deformity. It is called as gun stock deformity. So remember this, that in a supracondylar humerus fracture, there is going to be proximal migration, medial shift and tilt, internal rotation, and proximal tilt and shift. So the most important displacement here is medial tilt and internal rotation. If that does not get corrected, so in that child, because cast was put, they did not reduce the medial tilt and internal rotation. So the limb went into medial and internal rotation. So it went into cubitus varus deformity. So this is a gun stock or a cubitus varus deformity. The most common complication of supracondylar humerus fracture. It is actually a cosmetic deformity because the elbow functions in these patients are normal and patients will have a decreased carrying angle. The reason it's called as a gun stock deformity is this limb looks very similar to this long barrel of the gun. So that's why it's called as gun stock deformity. Remember one more MCQ here, that the treatment for gun stock deformity is a modified French osteotomy where you remove a wedge of the bone and you correct the deformity. Remove a wedge of the bone and correct that deformity. So that is a modified French osteotomy, and the treatment for this supracondylar humerus fracture or gun stock deformity. Okay, so that's what you have to remember. Now let's go into a few oncological questions, and here I will tell you an approach to remember oncology. So if you've gone through my sessions, if you've seen my sessions on bone oncology, I've taught it a little differently. There is an approach to understanding oncology and not just memorizing. So let's try to apply that algorithm here as well. Okay, so an 18-year-old complains of fever, pain in the lower limb, localized rise of temperature and tenderness in the region shown in the radiograph. ESR is raised. What is the most probable diagnosis? Is it Ewing sarcoma, osteosarcoma, osteomyelitis, or osteochondroma? A very good question was asked in one of the exams, in a NEET PG exam actually. So there is a lot of confusion between 3 options here. Okay, osteochondroma, I don't think anyone is thinking of this as osteochondroma, so let me rule that out first. But the students are often confused between 3 options: osteomyelitis, osteosarcoma, Ewing sarcoma, and I'll tell you why they think of this. Say they look at sun ray appearance in the periosteal region, sun ray appearance in that periosteal region, and they think that this could be osteosarcoma. Some people get confused because ESR is raised and they think it is osteomyelitis. and a lot of other people look at the diaphysis of the femur and they think this is Ewing sarcoma. So which approach is right? Which do you think is the right approach here? So let's understand how we approach bone tumors. If anyone has taken a session from me on bone oncology, this is how I teach bone tumors. I give you an approach to remember bone tumors where any x-ray you see, any clinical scenario you see, you have to ask these questions. What is the age of the patient? Which bone is involved? What is the location? What is the eccentricity of the tumor? What is the periosteal reaction? Is there any special reactions? What is the matrix of the tumor? So these are the questions you have to ask. So let's ask these questions here as well. So in that x-ray, was it looking like a benign or a malignant lesion? Look like a benign or a malignant lesion. See, in benign lesions, you have a narrow zone of transition, well-defined sclerotic border, lack of soft tissue, a solid periosteal reaction, and geographic bone destruction. In a malignant lesion, you have interrupted periosteal reaction like sun ray appearance, lamellated appearance. You have significant bone destruction, lot of soft tissue mass, and a wide zone of transition. So in our x-ray, it looked like a malignant lesion. Do you agree? It looked more like a malignant lesion. Okay. If you still have doubts, let's go further. Let's understand more things. Next is the age. And what is the age of a tumor? So in 0 to 20 years, most of the tumors are present. More commonly, you have Ewing sarcoma and osteosarcoma. Ewing sarcoma is seen more commonly in 0 to 10 years, but can be seen up to 20 years. Can be seen up to 20 years. In 10 to 20 years, more commonly you see osteosarcoma. 20 to 30 years, this age of 20 to 30 years, this is when we see fibrous dysplasia. 20 to 40 you see giant cell tumor, 40 to 60 you see chondrosarcoma or secondary osteosarcoma, and 60 years you see multiple myeloma, metastasis and chordoma. So these are all the tumors that you see. So from this we are not able to get a lot because our patient is 0 to 20 years. So most tumors can be there from 0 to 20 years. Then let's look at the bone involved. So which bone was involved there? It was a femur shaft that was involved. It was a femur shaft. So for femur shaft, this is the image that we commonly use. If you see my image of femur shaft, only one diagnosis is given, that is Ewing sarcoma. Ewing sarcoma. So with this, I've got the diagnosis. But let's go further. Let's try to understand more. Next, we see which area is getting involved. So we've gone through, this is the ABLE PSM mnemonic, ABLE PSM. So age we've got, bone we've got. Next is location. So location, is it diaphysis, metaphysis, epiphysis? This is a diaphyseal tumor. So it could be myeloma, adamantinoma, lymphoma, Ewing sarcoma, osteoid osteoma, fibrous dysplasia. Any of these could be the diagnosis here. So let's go into the next one, that is eccentricity. Eccentricity, nothing commonly is seen. So we go into periosteal reaction. So periosteal reaction, you have to understand a concept in periosteal reaction that if a patient has a solid periosteal reaction, imagine this is the bone, this is the periosteum. So if there is a tumor that is growing slowly or there is some infection that is growing slowly, you will notice that even the periosteum will slowly thicken. This will give a solid periosteal reaction. So a solid periosteal reaction is seen more in infections and benign tumors. Infection and benign tumors. Okay. But imagine you have an aggressive lesion. You have a lesion that is going aggressively. As the tumor grows, one layer of the periosteum will keep growing like that. So this will give a lamellated or an onion skin appearance, which is seen in aggressive tumors. It is seen in aggressive tumors, not in any specific tumor. It is seen in aggressive tumors. But if you have a tumor that is growing rapidly, and when it grows rapidly, this periosteum will stretch like this. The spicules of the periosteum will stretch like that, and you will see this sun ray appearance or spiculated appearance, which is seen in very aggressive tumors. And sometimes as the tumor grows, if the tumor keeps growing like this, the periosteum will get stretched here, and new bone will start to form here. So this will form a triangle like this. So this is called as a Codman's triangle. Codman's triangle seen in very aggressive tumor. Now you have conventionally studied that lamellated or onion skin is seen in Ewing sarcoma, and aggressive tumors like osteosarcoma, you have sun ray appearance and Codman's triangle, right? So this is what you have commonly studied. This is a table you studied. But this is not a rule. It does not have to be in every patient. If a patient has an aggressive or very aggressive Ewing sarcoma, he also can have a sunburst or a sun ray appearance. He also can have a Codman's triangle. Okay, remember this. It is commonly seen in osteosarcoma because osteosarcoma is a more common aggressive tumor. But sometimes Ewing sarcoma also can be an aggressive tumor, can present with a sunburst or Codman's triangle. Okay, so this is what you have to remember. So in this patient, let's use all of the things that we've learned. 1, 0 to 20 years. So could be many tumors. Malignant tumor. Okay, it's a malignant tumor. So it has to be Ewing's or osteosarcoma. It's a diaphyseal tumor, and we know which are the diaphyseal tumors. In that, Ewing sarcoma is the best one. Femur shaft, again Ewing sarcoma is the answer. And a sun ray appearance. Sun ray appearance can be seen in any aggressive tumor. So Ewing sarcoma is one of the aggressive tumors. So the answer based on all of this is Ewing sarcoma. It is Ewing sarcoma, not osteosarcoma. And for the students who have a doubt as to why Ewing sarcoma will have increased ESR and CRP, remember that I've given you a slide in your sessions where I've told you that an Ewing sarcoma resembles acute osteomyelitis. Patients will have intermittent fever and raised ESR, CRP, raised leukocyte count and anemia. So in Ewing sarcoma, infection-like features are commonly seen. Do not get confused. The answer is still Ewing sarcoma. Okay. So please use this approach. The mnemonic is ABLE PSM. If you want to learn more about how to approach orthopedic oncology, please go through my sessions on orthopedic oncology. Okay. So that was one of it. Another thing you have to understand is in Ewing sarcoma, you will see this pseudo rosette formation. So you will have these small blue round cells which look like pseudo rosettes. So these pseudo rosettes are seen. And another feature is it is a PNET tumor. So a case of Ewing sarcoma is a PNET tumor where you will have pseudo rosette small round cells. You will have stain positive for S100 and neuron specific enolase. MCQ2 gene will be positive. Translocation T1122 is there. This is important. This was asked as a question in one of the exams. And in Ewing sarcoma, you will notice CD9 positive, reticulin negative, and PAS positive. Okay, please remember these have to be memorized. So this is a recent update that you have to understand, that a PNET tumor has Ewing sarcoma. So Ewing sarcoma is one of the PNET tumors. These tumors are of mesenchymal origin, and the sarcoma arises from the medullary cavity, but it has a 1122 dislocation that changes the translocation that changes the developmental pattern of these cells, makes the tumor express ectodermal markers. So although this is a mesenchymal origin tumor, it gives out ectodermal markers. So you have to remember this. So let's answer another question on tumors. Here they've given you that a 8-year-old child presents with pain swelling in the mid thigh. X-ray shows a lamellated appearance and a Codman's triangle. Histology shows small round tumor cells which are positive for MCQ2. What is the diagnosis? Do not get confused here by Codman's triangle. Again, aggressive tumors of Ewing sarcoma can present with a case of Codman's triangle. And if you notice other keywords like small round cell, MCQ2 gene being positive, and lamellated appearance, all of this suggest, and also mid thigh suggests diaphyseal tumor. So all of this suggests that it is Ewing sarcoma. So the answer here is Ewing sarcoma. Okay. So that's how we go through the diagnosis of all of them. Now another important question asked, a very common bone tumor question that is asked. A 28-year-old woman presents with progressively increasing pain and swelling around the wrist for 4 months. No history of trauma. An X-ray of the wrist is shown below. What is the likely diagnosis? Is it osteosarcoma, Janssen cell tumor, chondroblastoma, or enchondroma? What do you think the answer to this question is? This is the X-ray. So you can answer the question just looking at the X-ray. And mind you, this is a very commonly repeated question. So you have to be able to answer this. Okay. So let's use our approach to answer this question as well. And remember this. Let's use this approach to answer the question. The first part is ABLE PSM. So let's go into that mnemonic. ABLE PSM. So we should understand the age, we should understand the bone, the location, the eccentricity, if there is any periosteal reaction, if there is any special reaction, and matrix. All of this we have to figure out. So age is 28 years. It is 28 years. Bone is distal radius. So let's look at our charts here. So age 20 years, most tumors are there between 20 years, 20 to 30 more commonly, which are the ones fibrous dysplasia and giant cell tumor. So out of these two, one could be the answer, but age is not the best criteria. So let's keep that aside and go to some other options as well. If you look at the bone involved, if you look at this chart, again this will give you the answer. So very important chart. I want all of you to remember as many fractures, as many tumors in this chart as possible. So if you look at distal radius, GCT, straightforward answer. It's giving you the answer directly. Even here, femur shaft, Ewing sarcoma, straightforward answer. So if you remember this chart, it will help you. So one was the age, second was the bone, third is the location. So if you notice the location in this tumor, if you look at the location in this tumor, let me go back. Yeah, if you look at this location, it is right close to the joint. So this is an epiphyseal tumor. This is an epiphyseal tumor. Do you agree? This is an epiphyseal tumor. So look here, what are the epiphyseal tumors that we know? We know the mnemonic ECG. We know the mnemonic ECG. E stands for epiphyseal tumor. C stands for chondroblastoma. And G stands for GCT. So we have two tumors, chondroblastoma and GCT, and commonly chondroblastoma is seen where the epiphysis is open. So it is seen in skeletally immature patient, and GCT is seen in skeletally mature patient. So in our question, it was a skeletally mature patient with an epiphyseal tumor. So the answer is again GCT. So we've confirmed it again. So through my bone involved, I've got the answer. Again, I've confirmed it with epiphyseal tumor. And if you look at the eccentricity, the tumor, if you notice, is eccentric. It is not central, it is not cortical, it is eccentric. So eccentric tumors can only be two, that is GCT and ABC. Okay, GCT and ABC. Again, if you want to understand these things properly, this is not the session to know that. I've discussed the approach very clearly in my session, so you can go back to that and see. But here you will just understand roughly about how to approach it based on the different clues that we have. And special features, you see some soap bubble appearance in that tumor, so that could be a chondromyxoid fibroma, giant cell tumor, adamantinoma. You see it is expansile as well, so giant cell tumor or aneurysmal bone cyst. So if you look at this tumor and use all the clues that you know, 20 to 40 years can be GCT, epiphyseal, skeletally mature patient, GCT, distal radius, distal femur also can be there, GCT, eccentricity, again GCT, expansile, seen in GCT, soap bubble appearance, seen in GCT. So we can confirm that the answer here is giant cell tumor. The answer is giant cell tumor, and this is a very important question. Every time in your NEET PG and INI-CET exam, oncology questions end up coming from GCT itself. It can be a distal femur GCT or a distal radius GCT, okay? And one confusion that students most of the time have is the difference between GCT and another such expansile type of lesion with soap bubble appearance, that is ABC, aneurysmal bone cyst. But the one difference you have to understand between ABC and GCT, which might look similar, is that this is the growth plate. This is the growth plate. So one tumor will be above the growth plate here. So it is a metaphyseal tumor. And another tumor will be under the growth plate. So it is an epiphyseal tumor. So if you see an epiphyseal tumor, that is GCT. If you see a metaphyseal tumor, that is ABC. Okay, this is the difference between GCT and ABC that you have to understand. So giant cell tumor theory, I won't go into that in detail. I want you to remember the 6 E's. Epiphyseal tumor seen in elderly 20 to 40 years, eccentric location, expansile lesion, has an eggshell cracking on touching, and extended curettage is the treatment option in these patients. And if you notice the histology, they'll have two types of cells, mononuclear cells and multinucleated giant cells. The mononuclear cells are actually the tumor cells, not the giant cells. The mononuclear cells are the giant cells, okay, or tumor cells. So now let's go into questions from the spine. So this was one of the questions asked in the last 2 year question, last 2 years back. So here you have a patient with pain radiating to the back of the thigh and leg after lifting weights. MRI is given in that image. It's a sagittal cut, and they're asking you which nerve root is most likely to be involved. Which nerve root is most likely to be involved? Is it L3, L4, L5, L2? Okay, try to read that MRI. For a minute, try to read the MRI. First you tell me the diagnosis, and then we'll go into the nerve root. Then we'll go into the nerve root. So if you see here, this is S1, this is the sacrum. Do you agree? This is the sacrum, this is L5, this is L4. So L4, L5, there is a very large disc like this. There is a very large disc that is seen. So the diagnosis here is an L4, L5 disc protrusion. L5, L5 disc protrusion or IVDP. Okay, you remember it as IVDP. If you don't want to remember disc protrusion, intervertebral disc prolapse. Now, which nerve root is affected? So to understand this, you have to go and understand the concepts a little bit. So what is a clinical feature of intervertebral disc prolapse? You'll have a young patient who will have lifted some weight or had some abnormal posture, now presents with acute low back pain, which increases on flexion, sneezing, coughing, passing stools, anything that increases the intra-abdominal pressure. And classically in patients with disc pathologies, they'll have a radiating pain down the leg, which is called as sciatica, and patients will have numbness and paresthesia. So this is a patient with IVDP, and if you look at the MRI, you saw that there was a disc that has come out like this, and that is called as a herniated disc, or also called as an IVDP, intervertebral disc prolapse. So intervertebral disc prolapse is when there is a tear in components of the disc which presses on the neural elements of the spinal canal. Lumbar spine is more common than cervical spine. L4, L5 is more common than L5, S1. In cervical spine, C5, C6 is more common than C6, C7. And investigational choice is an MRI. So we've seen that MRI. In that MRI, I've seen that patient has a disc pathology. Now we have to understand that disc herniation can be three types. It can either be central, which comes out like this, or it can be paracentral, which comes out like this, or it can be far lateral, which comes out like this. And commonly it is this area which I am marking here. This is the area that is weak. So the disc commonly come out like this, which is called as a paracentral disc. Okay, it is called as a paracentral disc. So it can be a central disc herniation, paracentral disc herniation, or a far lateral disc herniation. Most commonly it is a paracentral disc herniation that is seen. Okay, we've understood one fact. Then let's understand why that is important. Why is it important to know whether the disc is central, paracentral, or far lateral? Because if you look at the nerve roots, say for example, this is L4, L5. Okay, this is L4, this is L5 vertebrae, and this is the L4, L5 disc. In here, you will have two nerve roots. One is this nerve root, another is this nerve root. So the exiting nerve root comes out right under the pedicle of L4 and goes out through the foramen. That is called as the exiting nerve root. And L5 is a traversing nerve root. So at every level, you have one exiting nerve root, one traversing nerve root. And commonly, if it is an L4, L5 disc, this first digit will be the exiting nerve. The second digit will be the traversing. So let's take an example. Say an L2, L3 disc. L2 will be exiting, L3 will be traversing. Okay, that's how you will remember this. Now, why is this important? Because if there is a disc that comes out there, okay, where I have written C and P, it's a disc that comes out centrally or paracentrally. Which nerve root is it pressing on? Is it pressing on the traversing nerve root or exiting nerve root? It's pressing on the traversing nerve root. But if you have a far lateral disc there, that is pressing on the exiting nerve root. So this is how it looks like. So this is a traversing nerve root. This is an exiting nerve root. A central or a paracentral disc affects here. A far lateral disc affects here. And that is why patients have different nerve root involvement even though the disc is from the same level. Okay. So again, this is an example. Here you can see a far lateral disc which is pressing on the L4 nerve root at L4, L5. But if you look at the L5, S1, if you see this paracentral disc here, it's pressing on the S1 nerve root, the traversing nerve root. Okay. So in our patient, this is L4, this is L5. So the problem is at L4, L5. Okay, L4, L5 disc herniation is there, correct? So in this, L4 also can be affected, L5 also can be affected. But which is the most common disc herniation that is seen? It is paracentral. Do you agree? It is paracentral. So paracentral affects traversing or exiting? It affects the traversing. And which is a traversing nerve root in an L4, L5 disc herniation? It is L5. So L5 nerve root is affected. Do you agree? L5 nerve root is getting affected. Okay. So the answer here is L5 nerve root. Answer is L5 nerve root. So this is how you will approach this question. Now let's look at a little difficult question, something a little more complex in spine. I'm giving you these questions repeatedly because in the last 2-3 exams the trend has been to ask more spine questions. There have been questions from spondylolisthesis, from lumbar canal stenosis, from IVDP, so that you can expect one spine question to come up. So this is another question I want you to see. A 30-year-old man has back pain radiating to the left lower limb on lifting heavy weight. So this has to be IVDP, intervertebral disc prolapse. Young patient, radiating pain, lifted heavy weights recently. Weakness of extensor hallucis longus is seen. Okay, I don't know what to do with that information. He has some tingling and sensory loss over the dorsum of the foot. Ankle jerk is normal. Clinician suspects a disc prolapse. Correct, it is a disc prolapse. And to confirm the diagnosis, he is getting an MRI. Yes, MRI is the investigation of choice. What is expected in the MRI? So they're asking you what is expected from the MRI. How do you answer this question now? See, you have to use these information, that is weakness of extensor hallucis longus, sensory loss of the dorsum of the foot, and ankle jerk being normal. Why have they given you these clues? Because in nerve examination, by understanding the dermatome, by understanding the myotome, we are able to pick up which nerve root is affected. So if you understand a few information like what are the dermatomes, so different nerves supply different areas in giving some sensory supply. So C2 supplies the upper part of the head, C3 supplies the neck, C4 supplies the neck and upper shoulder, C5 supplies the anterolateral shoulder, C6 supplies the radial part of the arm, C7 supplies the middle finger and back of the hand, C8 supplies the ulnar part of the arm, ring and little finger. If you can't remember all of this, just remember this Vulcan sign, C6, C7, C8. C6, C7, C8 supplied by different parts in the hand. Okay. Then sensory supply, L1 is inguinal, L2 is medial thigh, L3 is medial knee, L4 is medial ankle and big toe, L5 is dorsum of foot, S1 is sole of foot and small toe, S2 is posterolateral thigh, and S3, S4, S5 is perianal region. This you have to memorize. If you can't remember this, just remember that L4 is inner ankle, L5 is big toe, and S1 is little toe. If you can remember these three things, that's the important dermatomes. Now myotomes, the way you remember them is, you have to take the limb away from the body and then close to the body. So elbow flexion, C5, wrist extension, C6, then you take it away from the body, C7, elbow extension, wrist flexion, okay, that is C7. Then you have to call someone, getting close, call someone, this is finger flexion, C8. Then you ask them to go away, this is finger abduction, okay. So this is how you will remember it, elbow flexion, wrist extension, then elbow extension, wrist flexion, finger flexion, finger abduction, that is C5 to T1. That's how you remember it. Then hip also, you have to remember it like this. Lower limb, you remember it as hip, knee, ankle, big toe. So these are the different joints. So L2 is at the hip. Hip is coming close to the body. Hip flexion, hip flexion. Then L3, you're taking the knee away. So knee extension, knee extension. Then L4 is at the ankle. You're taking the ankle away. So that is dorsiflexion. Sorry, you're taking the ankle inwards. You're taking it closer. That is dorsiflexion. Then L5, again you're getting the toe closer. That is great toe extension. And then again you come back to the ankle and you take the ankle away. That is ankle plantar flexion. That is S1. Okay, so these are the actions. L2 is hip flexion, that is done by iliopsoas. L3 is knee extension, done by quadriceps. L4 is ankle dorsiflexion, tibialis anterior. L5 is EHL or hip abductor. S1 is gastrosoleus, ankle plantar flexors. Okay, so this is how you'll remember them. And then reflexes, C5 is biceps, C6 is supinator, C7 is triceps, L3, L4 is quadriceps, S1 is ankle gastrosoleus. So how are you going to apply all of this in the question? Weakness of extensor hallucis longus, that is great toe extension, that is great toe extension, done by L5, done by L5. Sensory loss over dorsum of foot, dorsum of foot is again L5, dorsum of foot is again L5 myotome. Ankle jerk is normal, ankle jerk is S1, ankle jerk is S1, S1 is normal. So the problem is at L5. So find out where L5 is written. So L5 nerve root is written in two options here. One is L5 S1, one more is L4 L5, but we know S1 is normal. S1 is normal, so it can't be L5 S1, it is L4 L5 with L5 nerve root injury. So this is how it is commonly. Another way of understanding this is L5 nerve root is commonly involved. So common disc is paracentral disc. Paracentral disc causing traversing nerve root injury can only happen at L4 L5. At L4 L5 the traversing nerve root is L5. So this answer becomes much more clearer with that concept as well. Okay, so that's how you will remember it. So disc at L4 L5 compressing the L5 nerve root. Another question here, same scenario given, they've written left SLRT is positive, meaning left radiculopathy is there. Patient has a paracentral disc at L4 L5. What nerve root is more commonly affected? We know this. L5 is commonly affected. L5 is commonly affected. So the answer is L5 here. Okay. So that is the 13th question. Now another question, a patient has RTA, he is brought to the casualty, an X-ray is done. What is the fracture here? So look at this X-ray. Tell me what fracture is it? Is it a compression fracture, a chance fracture, a burst fracture, or a fracture of the spinous process of the vertebrae? Which fracture is this? Put your answers up in the comment. Okay. So to understand spinal fractures, I want to start with a Dennis concept of stability. In Dennis concept, it divides the spine into three columns. Column A is the anterior column. This column is anterior column, which has anterior longitudinal ligament, anterior annulus, and anterior 2/3 vertebral body. Middle column, this is the middle column. It has posterior 1/3 vertebral body, posterior annulus, and posterior longitudinal ligament. And posterior column, this is the posterior column that has posterior elements and posterior ligaments. So whenever a patient has only one column involvement, commonly anterior column, we call it as compression fracture. We call it as compression fracture. If two columns are involved, commonly anterior and middle, we call it as a burst fracture. We call it as a burst fracture. If three columns are involved continuously, that results in something called as a flexion distraction injury. Flexion distraction injury, which is also called as a chance fracture. Which is also called as a chance fracture. I'll show you all of them. So when you have a flexion injury like this, a patient will have only collapse of the anterior column, which is called as a wedge compression fracture, isolated failure of anterior column. It's a stable fracture because only one column is involved. So treatment is an ash brace like this. If you have a vertical compression fracture like this, you will have damage to two columns, anterior and middle column. So it will involve the middle column as well, and this is called as a burst fracture. It is an unstable fracture because two columns are getting involved. And the way you treat unstable fractures is by fixing the spine, and you fix it with something called as a pedicle screw. So the screws we put in the spine are usually passed through the pedicle, because then that screw will engage the anterior, posterior and middle column. So it is an ideal fixation. So you put pedicle screws like this. So you put one pedicle screw here, you put another pedicle screw here, and then you fix it with a rod. Okay, that is called as a posterior stabilization surgery in the spine. You can do it in unstable fractures. The third injury is an extension injury, where a patient is pushed downwards like that. He is pushed downwards like this, and when that happens, the fracture goes through and through the spine like this, and one side goes into flexion, the posterior side goes into distraction. So the whole area is involved, all three columns are involved. So you will have a fracture that happens mainly because of a seat belt injury. So imagine a person who's wearing a seat belt and he falls like that. The seat belt is pushing him back while he's falling front. So that can result in this injury. So it's called as a seat belt injury, because it also has a mechanism of jackknife. This is the jackknife. So your spine bends like a jackknife. It is also called as a jackknife injury. And because Chance is the person who termed this, it is also called as a chance fracture. So when you have three column fracture, we call it as a chance fracture, a seat belt injury, or a jackknife injury. This is actually a flexion distraction injury, where one anterior part is going into flexion, posterior part is going into distraction. Okay, so all three columns are involved in this fracture. Now look at our X-ray here. So this was the X-ray that was given to us. If you look at the X-ray carefully, you can see a fracture line that is going like this. So there is a damage here, there is a damage here, there is a damage here as well. So all three columns are involved. If all three columns are involved, we call it as a chance or a jackknife or a seat belt or a flexion distraction injury. Flexion distraction injury. So the answer here is a chance fracture. You can see the fracture is gone through all three columns here. Do you agree? So this is a chance fracture. Now another tip for all of you before we go into the next question. What do people forget the most during an exam? Is it the ID card, the admit card or the exam location? I've seen a lot of scenarios of people forgetting these things. So which do you think is the most common scenario? My experience as a teacher teaching a lot of students, I'll tell you what the most common scenario is. In an exam day, what I've seen students forgetting the most is their common sense. It is not an ID card, it is not the admit card, it is not the watch, not anything else. It is common sense. Because in exam, the most important thing, even if you've not been able to revise the last 2 days, the most important thing is that you have to be fresh before reaching an exam, because you have to apply your mind more than bring out whatever you memorized. You have to apply your mind in every question, and that is why my tip is the day of the exam and before that, get good sleep so that you are mentally fresh and you can apply a lot of common sense when you're answering these questions. Okay, so that is my tip here, because most students forget common sense and that costs them a lot of rank. Okay, now question number 15. This is a video question. Look at the video here. A football player has a twisting injury to the knee and clinically no bony injury is noted. What test is the examiner performing below? Is it an anterior draw test, a posterior draw test, a McMurray's test or a Latchman's test? Tell me this. 4 options. I'll play the video again. Look at what the examiner is doing to the limb. See the position of the leg. And can you tell me what the answer is? I'll play it again. So you can expect questions like this in the coming exam. They'll give you a video like this. So what do you think the answer is? Is it, see, the confusion will be between 2 options. Is it anterior drawer or is it Latchman? Okay, is it anterior drawer or Latchman? Or some people might even get confused by posterior drawer test. Okay, what do you think the answer is? So McMurray, I don't think anyone's going to get confused with. So again, let's go back to what we've understood. We know that there are different tests that we do in patients with sports injuries, because we are testing for collaterals, we are testing for cruciates, we are testing for meniscus in the knee. For the collaterals, we will do valgus varus stress, where we are trying to take the limb into valgus, take the limb into varus, and we are seeing whether it is medial or laterally opening up. That's why we know if there's an MCL or LCL injury. So that is a valgus and varus stress test. It can be done in full extension or in 30-degree knee flexion. Ideally, you should do it in 30-degree knee flexion, where you can see just LCL and MCL. Okay, so if you do it in 30-degree flexion, that is the best. But in our image, in our video, did we see the examiner doing a valgus varus stress? No, we didn't. No, we didn't see the limb going away. We saw the limb going front and back. Okay, it's not going away. So it's not this. It's not this test. The next test is the ones we do for cruciate ligaments. That is a ACL injury. You can do a Latchman and anterior drawer. In PCL injury, posterior drawer and Godfrey's posterior sac test. What we do in a anterior drawer and posterior drawer is we take the limb into flexion like this. So we take it into 90 degrees of flexion. We sit on the patient's limb so that we can keep the foot down, and then we hold the tibial tuberosity region and we take the leg front, we sag the tibia front. If you see some soft ending or there is any kind of increased movement or laxity when the limb is going front, that means the ACL is torn. If it posteriorly the same laxity is seen, that means PCL is torn. So this is the anterior drawer and posterior drawer test. Anterior drawer and posterior drawer test, 2 tests that we can do. But in our test, in our video which we saw, did we see the limb going into complete 90 degree? Was the limb completely, knee completely in 90 degree? No, it was not. No. So it's not the anterior drawer test. This was not the anterior drawer test. The next test is the Latchman test, which is a more sensitive test. Latchman is much more sensitive, because in Latchman you don't have to keep the knee flexed. There won't be tightness of the lower part of the leg, the quadriceps won't go into tightness. So a patient will easily be able to keep the leg in 30 degrees of flexion. 90 degrees of flexion in an acute injury patient might become difficult. So anterior drawer might become difficult. But Latchman is an easier test to do because you take the limb only to 30 degrees of flexion and you can stabilize the knee, and then you do that anterior sagging movement. So if you see some increased anterior movement, that means ACL tear is there. Okay, so this is a Latchman test, the more sensitive test for ACL injury. And then you do this Godfrey sag test where you check for tibial sag. Okay, that is for PCL. And for meniscal injuries, we do something called as a McMurray's test, where we take the knee fully into extension. Then if we are checking the medial meniscus, we take the limb front, we take it into flexion. So you can see here he's taking into flexion, he holds the ankle and he's externally rotating it. If you externally rotate it, you're crushing the medial meniscus between the tibia and the femur, crossing tenderness in the patient. Similarly, you take it into internal rotation and crush the lateral meniscus. So that is how you check for both the meniscus, and this is called as a McMurray's test. Similarly, you can do it in prone as well, where you grind and rotate the leg. This is called as the Apley's grinding test, but the best test for meniscus is when you press the joint line. Okay, but look at this video here. Again, let me play this video. What we are seeing here is the knee is in 30 degrees of flexion and they are just pushing the tibia frontward. So this is a test done for ACL, and the name of this test is Latchman, not anterior drawer. Okay, it is Latchman. So you have to understand the difference between Latchman's test and anterior drawer test. Okay. Now another question from sports injuries. A patient comes with meniscal tear in the right knee for repair. So which of the following zones of meniscus would you consider meniscorrhaphy? What is a meniscorrhaphy? Where you are repairing it, So the repair is only done in the red zone. It is done in the red zone where vascularity is good. So if you have not understood this, there are 3 zones in the meniscus. The vascularity is more towards the peripheral red zone. Middle is the red-white zone. The white-white zone is the inner one. If there is a tear in the white-white zone, because vascularity is less, it won't heal well. So in such cases, we end up shaving the meniscus. But if there is a red zone tear, we try to repair it. We do a meniscorrhaphy. So the treatment for red zone is a meniscal repair or meniscorrhaphy. For the white zone, we do meniscectomy or meniscal excision. Okay. So that is a treatment option. Now another pearl of wisdom before I go into the next question is make a plan for your NEET PG revision. Do not leave everything till the last week. Do not end up thinking I'll plan it some other time. This is the time where you plan what you're going to do in the last 2 weeks or 1 week of your NEET PG exam, because that 1 week of preparation, if done correctly, can make a big difference in your ranks as well. Okay, so this is my advice to you. Plan better. Your revision plan should be better. Now let's go on to another video based question. So this is another question where you can see what the examiner is doing. So look at the video and try to answer this question. So I'll show you this video first and then I'll show you your options. So see what the examiner is doing. Yeah, so see what they're measuring as well. So what do you think is the answer here? What are the things they're doing here? Let's look at that video again and I'll tell you what they're doing. First, they're insinuating their hand under the spine. They're insinuating the hand under the spine. And after that, after he's kept that spine there, what he's doing is he's taking the other leg, the opposite leg, into maximal flexion such that the thigh touches the abdomen. And sometimes you can ask the patient only to hold that limb. Here they have not done that, but most of the time we do that. And when we do this, what we notice is this limb which is there is now gone into flexion. It was not in flexion before, now it's gone into flexion. And what they're measuring at the end is the angle between that flexed limb and the bed, this angle between the bed and the flexed knee. So what they are actually measuring for, is it weak hip abductors? Is it fixed flexion deformity? Is it limb blend discrepancies? Or is it IT band contracture? Is it IT band contracture? What is this test? Can you tell me the name of the test? See, there should be no confusion in naming this test. Okay, so all 4 are different tests that are done. If you have a weak abductor, which test do we do? We do Trendelenburg's test. Do you remember this? We do Trendelenburg's test. When you have a fixed flexion deformity, what do? We do a Thomas test. We do a Thomas test. If we have a limb-led discrepancy, we do an Ali's or a Galeazzi's test. If we have an IT band, we do an Ober's test. We do an Ober's test. So 4 tests that we commonly do. This patient, we have done a Thomas test for fixed flexion deformity. What we normally do is, what you notice when a patient has a fixed flexion deformity. Let me show you this with the help of a bone model. See here. So if this is your hip joint, I'll show you like this. If this is your hip joint, if there is a flexion of the hip, if the hip is flexed like this, normally a patient will compensate. He doesn't want his hip to be flexed. So what he does, to reduce a fixed hip flexion, his spine goes into lordosis like that. His spine goes into lordosis. So this flexion deformity gets masked because of lumbar lordosis. So what you notice in these patients with fixed flexion deformity is, flexion deformity is hidden, but the lumbar spine has gone into lordosis. So what you do is, you will take the other limb into flexion. With that, the lumbar lordosis will get corrected. And as the lumbar lordosis gets corrected, this flexion deformity becomes obvious. This flexion deformity becomes obvious. And then you measure the fixed flexion deformity with the bed. So that is how you get this Thomas test. That is how you do a Thomas test. So what we are seeing here is a patient has exaggerated lumbar lordosis because it is masking the hip flexion. Now, if you take the other limb, if you take this limb into maximal flexion, the lordosis becomes straight. Can you notice how the lordosis becomes straight? So now you can notice the fixed flexion deformity. So that angle, this angle is the fixed flexion deformity, and this is called as a Thomas test. This is called as a Thomas test. So this is how it is done. You take the patient's limb into maximal flexion. That time you will notice this limb has gone into a fixed flexion deformity. Okay, so the way you do the test is, patient should be supine on the bed. You should flex normal hip to bring the knee of the normal side to touch the chest. There should be compensatory lumbar lordosis which gets obliterated. So what happens is, that hand which you kept is to check whether lordosis is getting obliterated or not. So there will be no space between patient's back and the table. Then you check the angle subtended between the thigh and the bed, which is a flexion deformity, which gets revealed at that time. That is a flexion deformity. Okay, so fixed flexion deformity is important. Other things you have to note about Trendelenburg test, about Ali's and Galeazzi's tests, and IT band contracture Ober's test. Those are important tests to remember. Now another video based question. Let's try to get you ready for your exam by seeing as many video based questions as possible. So look at this video based question. Here I'll first tell you the question, then you can see the video. Trendelenburg test is being performed on both sides. So you will notice in that video now that a patient will do Trendelenburg test on both the limbs. Which structure patient has a problem with? That is a question. Is it right superior gluteal nerve, left superior gluteal nerve, right inferior gluteal nerve, or left inferior gluteal nerve? So let's look at that video. Shall we look at that video? Yeah, see here. So patient is now standing on the left side. Now the patient is standing on the right side. Do you notice a difference? Again, look at it. He is standing on his left side. Now he is standing on the right side. Do you notice something different here? Please put up your answers in the chat box. If you notice anything different, put it up in the chat box. If you know which nerve is involved here, put that up in the chat box as well. So let's wait for the answer. You want to see the video again? I'll play the video again for you. Okay, have you found the answer now? Have you understood what has happened here? Okay, another way. So this is the way I expect questions to come in the present exam. In your previous exam, this was the question that was asked. Again, same question, just without video, they've given you words. A patient has difficulty climbing stairs. When he was made to bear weight on the right lower limb, the pelvis dropped on the left side. Which structure is involved here? Is it the right superior gluteal nerve? Is it the left superior gluteal nerve? Is it the right inferior gluteal nerve or the left inferior gluteal nerve? If you can answer the question with these wordings, let's see if you can answer them like this. Now I've changed the way question was put. Instead of the video, I've given you the scenario. Okay, so let's try to answer this question. Let's try to decode this question. Let's try to decode this question. Okay, so what is a Trendelenburg gait or a Trendelenburg test? So it is seen in patients when they have weak abductor muscles because of any cause. So see what happens in a normal abductor. When you're standing on one side, imagine you're standing on this side, this limb here, you're standing on this limb. All of the weight that is there is now suddenly being shifted that side. So the pelvis might not be able to hold all of this balance. So the pelvis should normally fall like this downwards. It should fall like this downwards, as you can see here. But because you have strong abductors on this side, on the side that you're standing on, that abductor will pull the pelvis back to normal. It will pull the pelvis back to normal. So the abductor on the side you're standing on sees to it that the pelvis does not drop down to the opposite side. Okay. But now imagine a patient who has a weak abductor on the same side. So imagine he has a weak abductor on the right side. So if I make this patient stand on his right leg, you will notice that his pelvis drops to the left side. So if the pelvis drops to the left side, the problem is on the right side. Let's remember it another way. This is the unsound side, right side. This is the sound side. So if the patient stands on the unsound side, the pelvis drops to the sound side. So the mnemonic to remember Trendelenburg test is sound side sinks. Sound side sinks. Okay. So this is how you'll understand this. So see here, this is a Trendelenburg test. In this, I'm making the patient stand on his sound side. Nothing is happening to the pelvis. He is balancing. He is able to stand normally. Now I'll make him stand on his unsound side, and now what you will notice is this is dropping towards the sound side. So here, sound side sinks. Do you agree? Sound side sinks. Where is the problem here? The problem is here. These hip abductors are weak. These hip abductors are weak, because of which the patient's pelvis is dropping towards the opposite side. So that is the Trendelenburg test, where when you stand on one leg, when one stands on a single leg, the opposite side pelvis is lifted up to clear the ground, and this is done by the contraction of the abductors. But if the abductor mechanism is defective, the opposite side pelvis will sink down due to gravity, which is called as sound side sinks, and that is a positive Trendelenburg test or sign. And along with this, as the patient falls down to the opposite side, to balance himself, he will lurch towards the same side. As he is falling, his pelvis is falling to one side, he will lurch towards the same side. So the pelvis sinks towards the opposite side, the patient lurches towards the same side. Okay, the pelvis sinks towards the sound side, whereas the lurching happens towards the unsound side. This is how you will remember it. And this another form of it is whenever the patient walks. As he walks also, you will notice a typical gait which is called as Trendelenburg gait. As he puts the leg on the defective side, the pelvis will sink to the opposite side, and then when he changes and goes to the normal side, nothing will happen. Again, he'll put his foot towards the defective side and the pelvis will sink. So if it happens unilaterally, it's called as Trendelenburg gait, but if it happens bilaterally, both sides, the patient will waddle like this. It's as if the duck is walking. So that's called as a waddling gait. It's called as a waddling gait. Okay. So look at this video here. This is the same patient. He has a right hip abductor weakness. So you can see as he's walking, when he puts his weight on the left leg, his pelvis is sinking. It's sinking towards the right side. It's sinking towards the left side. When he puts weight on the right side, his hip is sinking towards the left side, and that is a Trendelenburg gait. So how will you answer this question? So a patient, when he bears weight on the right lower limb, the pelvis is dropping towards the left side. So this has to be the sound side. Left side is the sound side and the right side is the unsound side. Do you agree? The right side is the unsound side. So what is the problem here? Patient has a right abductor weakness. right abductor weakness. And what are the right abductors? What are the hip abductors? They are gluteus medius and minimus. Gluteus medius and minimus. And which nerve supplies the medius and minimus? That is superior gluteal nerve. That is superior gluteal nerve. And gluteus maximus is supplied by which nerve? That is the inferior gluteal nerve. But gluteus maximus is not a hip abductor, it is a hip extensor. So we have to worry about superior gluteal nerve. So which superior gluteal nerve will be affected, right or left? It is right side, because we know right is the unsound side. So right superior gluteal nerve is the answer. So this is how you will answer that question. Okay, if you understand the Trendelenburg test, you understand which muscles are the abductors of the hip, you know what is the nerve supply of that abductors, then you can answer all three layers of the question and you can answer this. Even in the video based question, you will be able to notice the same thing happening. So let's go back and see that video based question again. I want you to answer that video based question also correctly. So let's go back to that. So here, if you look at this video, he's standing on his left side, normal, pelvis is maintaining. Now he's going to his right side, and as he goes to the right side, do you see the pelvis dropping? Do you see one of his buttocks going down, which is the left buttock? Can you see here? Can you see here? Yeah, this is the left buttock that is going down. So it is going down. So the unsound side is right, the sound side is left. The sound side is left. Okay. So in this patient, the unsound side is right. So it has to be a right superior gluteal nerve injury. Okay. This is how you will answer those questions. Okay. Now let's go to the next question. Again, a Trendelenburg question itself. Patient standing on one side has Trendelenburg sign positive. What is the action of the muscle tested in the Trendelenburg test? And this normally for Trendelenburg, we're testing the gluteus medius and minimus, which is important for internal rotation and abduction. Abduction and internal rotation. So 1 and 4. So answer has to be D. D is the answer. Okay. Abduction and internal rotation. Now question number 20. This is a nerve based question. Identify the nerve and the muscle action being tested in the examination. Is it ulnar nerve, dorsal interossei, medial nerve, flexor pollicis longus, median nerve, adductor pollicis, and ulnar nerve, adductor pollicis? This is the image they have given you. Someone's holding a book or someone's holding a card like that. Okay, the question can be asked like this, or in the coming exam, because there are going to be video based questions, they can give you a question like this. A failure to perform this test is most suggestive of paralysis of which of the following muscles? And let me show you this video. Look at this video. This is the patient, this is the examiner. Look at the fingers of the patient. What is different here? What is so different here? Okay, with this, can you answer this question as well? Which muscle is affected? Is it adductor pollicis, palmar interossei, abductor pollicis brevis, extensor brevis? I want you to pause both the questions and try to answer them. Okay. So this is question 1. This is question 1. Look at this. Write down your answers. Look at this image. Look at which is it. And then this is your video. That's the video that you're seeing. Here your question is, which muscle is paralyzed? So tell me both of these questions answer. Put them up in the comment box. I will give you a minute to think. All right. So we have to understand that the answer to that question was actually ulnar nerve, and in ulnar nerve it was mainly the adductor pollicis. This adductor pollicis, because the test that was shown to you, the second test was a book test. In book test, what you're testing for the adductor pollicis muscle. Okay, you're asking the patient to hold the book in one hand, you're holding the book in one hand, and both of them are pulling it on both sides. If the adductor pollicis is weak, the patient, to get good grip of the book, what they will do is, because adductor is weak, they will flex their finger like that and hold it, because flexor pollicis longus, which is given by median nerve, that is normal. So holding like this, they will try to pull. If you notice that video as well, I'll go back to that video again. If you notice this video here, you can see that patient's right hand, the fingers are going into flexion. Can you see the fingers are going into flexion? So this is classically a failure of ulnar nerve, adductor pollicis and flexor pollicis acting there to keep that grip. Okay, so in both of these cases, this is a Froment sign. So the answer here is ulnar nerve and adductor pollicis. This is the book test. Answer here is adductor pollicis. Okay, so book test and Froment test is the test that we are doing. So if you want to check for palmar interossea, you keep a card, and palmar interossea helps in adduction. So adduction should be strong. The next one is the Igawa's test that you do for dorsal interossea. Then for abductor pollicis longus, you keep a pen and test for the pen test, that is a pen test. And then in pin palsies, all of this I think you can study. I'll just go into the next question. So these are the important tests, and I want you to study nerve tests very clearly. You have to understand all of them. I've just given you one example of how a question can come up. I want you to go back and go through your theory if you've not understood this. Okay, so that was the important tests that are required here. So the answer here is ulnar nerve and adductor pollicis and adductor pollicis here. Now let's go into question 21. Again from trauma. A 83-year-old lady comes with history of trivial fall in the bathroom. She complains of pain and swelling along the wrist joint. X-ray is done. You can see the X-ray here and here. The orthopedic resident instructs you to perform close reduction and apply a cast to this patient. Okay, they are asking you about the treatment option. Which among the following is a right method of reduction? So this is a very good question, because here first you have to diagnose what the problem is. Then you have to talk about reduction maneuver. So which fracture is this? Can you tell me which fracture this is? See here what you're noticing. You have to first identify where the thumb is. So this is where the thumb is. So this is the volar side. This is the dorsal side. And I can see a fracture. And the fragment has gone to the dorsal side. And if you see, the fracture is away from the joint. It is away from the joint. So this is an extra-articular fracture with dorsal angulation of distal end of radius. So this is a classical Colles fracture. Do you agree? This is a classical Colles fracture. And in Colles fracture, what is the reduction maneuver? So this is a Colles fracture. Can you see? This is how you should outline them. So this is a Colles fracture, and the displacement in Colles fracture is dorsal tilt and displacement, impaction, lateral tilt, lateral displacement, and supination. Do you agree? The mnemonic is DILS. Okay, the mnemonic is DILS. How do you reduce them? So look at this animation. Let's start with the upper one. In the lateral view, what we do is we have to reduce the impaction. So how do you reduce the impaction? You will give traction, counter traction. Can you see in that image? Traction, counter traction. The fragments have reduced now. They have come out. The impaction has reduced. What next? There is dorsal angulation. So how do you correct dorsal angulation? It is like this. So you have to give palmar flexion. So you do palmar flexion. So that corrects the dorsal angulation. Now look at the AP view. In the AP view, what is there? It is angulated radially. So you have to do a lateral deviation. So you have to do a ulnar deviation. So you do an ulnar deviation. So here, if you can look at this animation now, traction, counter traction, impaction is corrected. Then you do a ulnar deviation. So the treatment is disimpaction, palmar flexion, ulnar deviation, pronation. And after doing this, you apply a cast in which the hand is like this. It is similar to how kings used to kiss on that hand. So that was called as a handshaking cast. So this is how the handshaking was done. So this is a handshaking cast. This is a handshaking cast. So this is how you do it: traction, counter traction, palmar flexion, ulnar deviation, pronation. Last you do pronation. Okay. So you're correcting all the deformities that were there. Now coming to question number 22, again an image based question here. They've given you 4 implants, A, B, C and D, and they're asking you to match with the description: dynamic hip screw, femoral intramedullary nail, tense nail and tibial intramedullary nail. So what do you think each of them are? Try to comment. If you know any one of them, you can tell me. If you know A, you can put that up in the comments saying that A is this. Okay, so the way you understand this is that to put a nail in the tibia, this is how it is done. To put a nail in the tibia, if you can see, there is an angulation. Anteriorly you have to put it. So this is how a tibial nail goes inside. Look at that video. Now they put a rod. Yeah, that's how the nail goes inside. If you see, this nail, to go inside, it has a curvature, so it needs this bend. Any nail that goes to the tibia requires this bend, and this is called as the Herzog's bend. It is called as the Herzog's bend. So any tibial nail will have a bend, acute bend like that. Whereas if you're using a nail in the femur, it will not have that much of a bend, just a small curvature like this. Okay, so this is a femur nail. This is a femur nail. So this is how you put a femur nail. Okay, that's how a femur nail looks like. Then you have an implant where there is a screw and there is a side plate. So you put the plate and you put a screw, and the screw slightly slides under the plate, and because there is movement, it is called as dynamic hip screw. It is called as dynamic hip screw. Again, this is also used in proximal femur fractures. And the last is those thin screws, thin implants that you can put like this. Can you see how that implant is going inside? So this is basically a nail which is very thin and elastic. So it is made up of titanium as well. So it is called as a titanium elastic nail system. So you put multiple of them inside. You can put 2 tense nails inside. So it's called as a tense nail. Okay, titanium elastic nail system. So if you look at the options here, I think we will not cover this. Yeah. Sorry, I'll go back to that and let's see the options here. Yeah. So here, can you see that there is a bend? So this is a tibial nail. Here there is just a curvature. So this is a femoral nail. Here you can see there is a screw and a side plate. So this is a dynamic hip screw. And here you can see 2 thin nails. So this is a tense nail. So option A is a tibial nail. Option A is a tibial nail. Option B is a femoral nail. Option C is a dynamic hip screw, and option D is a tense nail. So 4213. So where is that? 4213. So this is to be the answer. That is the answer. Okay. So that's how you solve questions like this, and these are all the implants that you need to remember. Okay. Next question, another video based question here. Identify the splint used below and the injury it is used for, and you have 4 options: static cock-up splint, radial nerve; dynamic cock-up splint, radial nerve; dynamic cock-up splint, ulnar nerve; knuckle bender splint, ulnar nerve injury. Can you tell me the answer to this question? Can you see what they're doing there? This is the implant, and there's a video of a patient wearing that implant, and what is happening? Can you tell me which implant this is and which nerve is affected? Show you the video again. So here if you see, whenever you have an implant, whenever you see any kind of implants like this, especially in nerve injuries, you have to see what the implant is doing to the finger or that hand. See, in this patient, the patient's implant is keeping the fingers from dropping down. It is lifting the hand up. So what is the problem in this patient? His fingers are dropped down. So this is called as a finger and wrist drop. And where do you see a finger and a wrist drop? You see it in radial nerve injury. So this patient has a radial nerve injury. Now what is the implant that you use in radial nerve injury? You are keeping the hand up. It is cocked up. So it is a cock-up splint. And there are 2 types of cock-up splint. One is a static cock-up splint where you have a padding that holds, you have a pad like this that holds the finger together, or you have a lot of mechanisms of springs which help you do dynamic movements. That is called as a dynamic cock-up splint. Here in this video, I can see there is a lot of mechanisms, some springs are there which are helping the finger dynamically move. So this is a dynamic cock-up splint used in radial nerve injury. It is used in radial nerve injury. So that's how you will remember. This is a dynamic cock-up splint. This is a static cock-up splint. These are used in radial nerve palsies. This is a knuckle bender splint. This is a knuckle bender splint which we use in ulnar nerve. This is an aeroplane splint which we'll use in Erb's palsy. This is a turnbuckle splint. Where do we use this? In Volkmann's ischemic contracture. And this is a foot drop splint or an AFO splint. Where do we use this? In patients with common peroneal nerve injury or foot drop. Okay, so these are the important implants to remember. Cock-up splint is used in radial nerve palsy, knuckle bender splint used in ulnar nerve palsy, turnbuckle splint used in Volkmann's ischemic contracture, aeroplane splint used in brachial plexus injury, Erb's palsies, thumb abduction or opposition splint, they might not give you an image of this, used in median nerve palsy, ankle foot orthosis or foot drop splint used in common peroneal nerve palsy. So that is the question. Now let's go to the so that was the 23rd question. Now let's go into the 24th question, another video based question for you to understand. So we have 2 more questions before we end this session. So look at this video now. Again, like I told you, gait can be an important video based question. So this type of gait is seen in is the question. So can you see the image here? How is the patient walking? How is this patient walking? What type of gait is this? Can you tell me what gait this is? Put up the answer and put up what type of gait do you see as well. Both I want both of this. I'll show you the video again. I hope a few of you at least get this answer right. So this actually is a hand to knee gait. If you notice here, the patient is keeping his hand in the anterior part of his knee whenever he walks. Why is this? Because whenever we walk, we want our knee to be extended and it has to be locked. Okay, but in some patients with quadriceps weakness, because of quadriceps weakness, the knee buckles whenever they walk. Knee does not stay in extension, it goes into flexion and the patient's knee buckles as he walks. So this patient, to prevent that buckling and falling to happening, he takes his hand and he keeps it on the anterior aspect of his knee or little proximal to the knee, so that he can keep the knee extended as he walks forward. So the problem here is quadriceps weakness, and this quadriceps weakness is commonly seen in patients with poliomyelitis. So poliomyelitis is the answer here. So this type of gait is called as a hand to knee gait. Hand to knee gait, and it is commonly seen in patients with poliomyelitis. So in patients with polio, due to quadriceps weakness, they have inability to lock the knee while walking. So patient puts his hand on the knee to prevent it from buckling, and that is called as a hand to knee gait, commonly seen in patients with poliomyelitis. Okay. Now the last question of the session. A 30-year-old woman is brought to the emergency department following a high-speed road traffic accident where patient suffered a dashboard injury. On examination, affected lower limb is held in characteristic abnormal position as shown in the image. What is the likely diagnosis? Is it anterior dislocation, posterior dislocation, fracture neck femur, or intertrochanteric fracture? Can you tell me the answer to this? See, the way to remember this, I have 2 animations I'd like to show you. So hip dislocations can be anterior or posterior hip dislocation. They can be fracture dislocations as well, central, anterior and posterior, but commonly anterior and posterior pure dislocation. So normally when a patient has a dashboard injury like this, a dashboard injury, in them, if you look at what happens to the limb, can you see what is happening to the limb? I'll show you again with this and this bone saw model as well. So the knee is flexed like that, and as the patient, so let's keep it like this. Yeah, so the knee is flexed, and when the impact happens on the knee because of a dashboard injury, the hip, this femur socket which is there, the proximal femur and the head of the femur will come out like that. It will come out like that and it will lie posteriorly, and if you look at that limb, the limb gets locked in adduction, internal rotation and flexion. So the limb now is getting flexed, adducted and internally rotated. So the attitude of the limb in a patient with posterior dislocation is flexion, adduction, internal rotation. Can you see that image there that tells you that there's flexion, adduction, internal rotation? So posterior hip dislocation is commonly a dashboard injury where the femoral head is forced out of the acetabular socket posteriorly. In them, the limb goes into flexion, internal rotation, and there will be adduction. There will be adduction. Okay, so that is the clinical feature. Patient will have a shortened leg, femoral head is felt in the gluteal region, there will be vascular sign of Nanath which is positive. But in a patient with an anterior dislocation where the leg goes away, what do you notice? So look at this, the patient's leg is going into flexion. Do you agree? It's going into flexion. It is going into abduction and external rotation. So in a patient with an anterior hip dislocation, leg is going into flexion, abduction, external rotation. So in anterior hip dislocation, commonly you see it in fall from a tree when the foot gets stuck and hip abducts excessively, or road traffic accident, the femoral head is pushed out of the acetabular socket anteriorly, and in these patients this is the attitude. It goes into flexion, abduction, external rotation. The mnemonic here is Faber. The mnemonic in posterior dislocation was FADIR, F-A-D-I-R. So flexion, abduction, external rotation, true lengthening of limb. Femoral head is felt in the groin, Scarpa's triangle and femoral triangle. So the algorithm to remember hip dislocations, even if they ask you a complex fracture dislocation question also, this part of the algorithm will help you. So what you do first is see where the femoral head is felt. If they tell that in the patient femoral head is felt in the gluteal region, that means it is a posterior dislocation. If the femoral head is felt in the groin or femoral triangle, that means that the dislocation is anterior. If it is felt perrectal, then that is a central fracture dislocation. That is different. Now, if the head is felt in the gluteal region and you have this classical attitude of flexion, adduction, internal rotation, then it is pure hip dislocation posteriorly. Pure meaning there is no fracture. It is just a pure fracture hip dislocation, pure hip dislocation posteriorly. But if the patient has a head that is in the gluteal region and the attitude is mixed, it is not flexion, adduction, internal rotation, it gives me something else, then this patient has a fracture dislocation. That's why the attitude has changed. But the head is still gluteal, so it has to be a posterior fracture dislocation. Same way, if the head is felt in the groin femoral triangle and the attitude is flexion, abduction, external rotation and limb lengthening is there, then it is an anterior pure hip dislocation. If it is a mixed attitude with femoral head felt in the groin or femoral triangle, then it is a anterior hip fracture dislocation. I know this might seem complicated, but the day they ask you about fracture dislocations, that attitude of Faber might not be there. That's why you have to remember about fracture dislocations also. What will be the presentation? So this algorithm will help you understand that. Okay. So with this, we've covered very important 25 questions. So my only advice to you is that this session should serve as an understanding for you to understand what type of questions will come, from where image based questions can come, from where video based questions can come. How do I go about solving long clinical questions? So this is the takeaway from this session. And now going forward, how many days are left for your exams now? Try to practice such questions, long clinical questions, image based questions, video based questions and PYTs, previous year topics rather than previous year questions. If you have any doubts, my WhatsApp group is available where you can text me and I can answer your questions back. I have an Instagram handle where I put up image based questions, where I put up interesting orthopedic facts which will help you in your NEET PG and INI-CET journey. I hope all of you do well in your exams. Happy learning.